Thank you very much. I'm excited to be here at this wonderful Congress and to get the opportunity to talk about this topic, which has really grown dear to my heart, not only from a research perspective, but also through the many rewarding interactions with the patients and their families. So I don't have anything to disclose. The only thing I disclose that I put the inherited in quotes, as I want to convince you that it's not necessarily always inherited, because then we think about the classical family history and that might not always be present. So as a short overview, I'll start with an introduction, then focus on the clinical aspects of hereditability of ACC, and talk then about the familial cancer syndromes in ACC patients in a little bit more detail. And then just shortly comment on the germline analysis of big data, and we'll finish with some summaries and recommendations. So cancer genetics, which is one of the clinics I do once a week, what's the scope of that? And very often that is actually seen as a conglomerate of very rare diseases. And if you think about something like the classical Li Fraumeni syndrome, it's certainly rare. It's 1 in 250,000 probably as a prevalence. MEN1 is rare. But when you get to Lynch syndrome or BRCA1 mutation, that actually becomes way more common. And if you look at certain population, it actually reaches something like, for example, here up to 20%. So I would like to convince you that actually altogether these familial cancer syndromes are not rare. And even if you take all those really rare ones together, about 10 to 15% of all cancers are probably caused by monogenetically inherited conditions, which makes it actually possible to identify those in your patients. A short historical overview. This is all started with a publication by Fraumeni in 1967, who described several features of probably congenital predisposition to adrenal cancer development with children who had other manifestations, such as other tumors or actually siblings with the same disease. Now, the approach to finding genetic associations can be twofold. And what you see on the left side of the screen here is actually the clinical evaluation as we do it in the clinic. We take a history and then finally come to diagnostic criteria, and then that leads to further genetic confirmation with genetic testing. On the right side, that's more the research approach, where you start with a group of patients who have something in common, as in this case the adrenal cancer, and then do unbiased sequencing, usually exome sequencing, on which one of our chairs, Guillaume, gave a very nice talk yesterday. And you'll end up with known disease-causing mutations and known genes, or even with new genes. Okay, I'll focus first on the clinical approach. And there are certain characteristics which are actually important to keep in mind when evaluating patients for inherited tumor syndromes or tumor predisposition syndromes. So the first thing here is metachronous or bilateral adrenal cancer. When we looked in our collective of our patients in Ann Arbor, about 5% had bilateral tumors, which is not necessarily, of course, metachronous ACCs. Often this is probably metastasis, but it can be also another ACC. When we look at other primary tumors in our ACC cohort, what's of course important is to look how many tumors are in those patients, and certainly something like 3 or even 4 tumors in patients that is already suggestive for an inherited tumor syndrome. The spectrum of tumors or the specific tumors can give clues as well, like for example neuroendocrine tumor, as we know that from MEN1, or sebaceous carcinoma, which is one of the core cancers of Lynch syndrome. So 9% of our patients actually had known adrenal lesions before, which goes a little bit along the lines that there might be actually a progression from precursor lesions to ACCs. ACC seems to be a little bit more common in children. This is also data from our registry. There seems to be a small peak here during childhood, which is not that evident, but taken the otherwise real rarity of these cancers or general cancers in children, there seems to be a real peak, and that's another thing that's suggestive of ACC actually having a genetic basis. Of course, it's always important to look at other features, for example, endocrine features such as primary hyperparathyroidism, which was present in 2% of our patients, and certainly in all of our MEN1 patients who developed adrenal cancer. Another good thing is always to do a detailed physical exam, and those are all lesions which we observed in our patients, which then were actually a tip-off for underlying genetic syndrome predisposing these patients to cancer development. So what about the family history? Family history is, of course, on the core of defining that there is something inherited going on predisposing these patients. And there were some families which had a striking number of cancers. It's, of course, always important to see what's the pattern. For example, if that's all colon cancer, that makes you suspicious of Lynch syndrome. And others, like, for example, the Triton tumor or something, they can be associated with Li Fraumeni syndrome and p53 mutations. And we're currently in the process of actually calculating the standardized incidence ratio in these families and identify whether there is any higher than expected numbers of cancers in the family relatives of our patients. So, but genetic predisposition is not just for kids, as the early description by Fraumeni suggested. I would like to convince you today that it actually really makes sense to look in the adult population as well. So, probably the best well-known syndrome is actually Li Fraumeni syndrome, which was initially described in 1969 by Li and Fraumeni. It's a mutation in the p53 gene, and it comes with certain core cancers such as sarcomas, brain cancers, adrenal cancer, and choroid plexus tumors. And it's interesting that actually if you look here, which kind of shows the frequency of these tumors by age, is that they have a little bit of different peaks. In adrenal cancer, you see the big peak here is actually during childhood, and I'll go back to that later, but there's certainly a presence in during adulthood as well. Breast cancer then comes on more in the 20s or 30s, for example. So ACC is a classical childhood tumor, and about 50% of all kids with ACCs actually have Li Fraumeni syndrome with underlying p53 mutations. Now, how do we diagnose Li Fraumeni syndrome? And like with every genetic disease, there are the genetic criteria, the classical criteria. I'm not going to go through this in detail, but they're very, very stringent. And then there are those criteria like the Birch and Eales criteria, which are a little bit more loose and describe Li Fraumeni-like syndromes. For example, Eales is only 2 different tumors of the extended Li Fraumeni spectrum in first and second degree relatives, which is exactly a very loose criteria. And then we have the testing criteria, so how to identify patients who should be tested for p53 mutations. And the only thing I would like to point out here is that actually the Chompré criteria define that patients with adrenocortical carcinoma, irrespectively of family history, should undergo testing. And that was actually the basis for a study we conducted a while ago in our Michigan Endocrinology clinic. And everybody there, every consecutive patient received genetic counseling, as well as a full risk assessment, and offered p53 testing based on those Chompré criteria. And this is a busy table, but what I would like to focus on here is that 94 patients were counseled, 53 were tested, and you already see a discrepancy here, which is mainly due to 3 main reasons, which was the desire to discuss this with family members prior to testing. A lot of our patients are traveling from nationwide, and they would like to discuss this at home. They wanted to check insurance coverage and possibly pursue that within their healthcare network, or the insurance is flat out denied p53 testing, which is, of course, unfortunate. Of the 53 patients tested, 4 tested positive. 1 of those was a child. The other ones were adults. And if you actually look at the criteria which I mentioned before, the classical and the Li Fraumeni-like criteria, what is important here is that none of our patients actually fulfilled classical Li Fraumeni syndrome criteria despite having a p53 mutation. And the other thing that is important, if you actually look what criteria they fulfilled, they don't even fulfill the Birch criteria, only the very, very loose Eales criteria, and of course, they fulfill the Chompré criteria. So in summary, of our adult population, roughly 5% had a p53 mutation, and at that time that was also published by our colleagues from Würzburg with roughly numbers in the same range. So one of the messages here is a negative family history does not exclude Li Fraumeni syndrome. So every patient, in our opinion, should have p53 testing. even a negative family history should not exclude testing. Up to 25% are actually de novo mutations, so they don't have a family history. And one of the reasons why we test our patient for our patients themselves is because we try to avoid radiation therapy in our Li Fraumeni patients unless it's absolutely necessary for treatment. P53 mutation cause ACCs in pediatric and adult patients, and that had been recently published also by John Wasserman from Toronto, where you see that up to 50% of children here at young ages have germline mutations. But still, even in the adult, it ranges between 2 and 10% of patients. So it is fairly common in adrenal cancer patients. Now, one of the questions, of course, can we prevent ACCs in our Li Fraumeni patients? And I'm not going to go into detail, but there have been 2 studies who focused on this, and with ultrasound and biochemistry with a very rigorous screening schedule, and they were actually able to detect some ACCs, and it looks like they did a little bit better than the ones in the non-surveillance group. But this is really something which is still in flux, and I think this is a very individual discussion with the family. So we offer actually annual whole body MRI or ultrasound with a physical exam. And I think what's really important is to actually counsel these families about symptoms of ACC, because most of these childhood tumors are actually hormone producing, so it's important to inform the family about things like precocious puberty or things like that. So the other syndrome we came across was actually Lynch syndrome, which is hereditary non-polyposis colon cancer, causes 2 to 4% of all colon cancers, 80 to 100% lifetime risk of colon cancer. It's due to DNA mismatch repair, gene mutations, and associated with some other core tumors. And really the main important thing here is that surveillance of carriers with these mutations with regards to the colon cancer can actually really reduce the morbidity and mortality basically to population level, and is very cost effective, which is, of course, an important fact for screening family members. So what was known, at least 4 cases had been described, all with MSH2 mutations. And interestingly, Henry Lynch's first family N was actually ascertained by a proband here with an adrenocortical carcinoma at age 44. So there had been suggestions around. In our 94 consecutive patients, we found 3 patients with disease-causing mutations in MSH2, MLH1, MSH6. When we looked a little bit further then in our cancer genetics registry, there were another 2 patients of a total of 123 probands with Lynch syndrome who also had ACC. So the good thing about Lynch syndrome is that we actually don't need to directly go to genetic testing. We can actually screen for this. It's basically this complex here is 2 heterodimers of MSH2, MSH6, and MLH1, PMS2, which repair mismatch base pairs in the primer strand. And we can screen with 2 different methods. Usually mutations lead to absence of the protein in IHC, and mismatch repair deficiency also leads to microsatellite instability, usually to a shortening of these microsatellite repeats. So immunohistochemistry worked fairly well in our available tumors. You see, for example, the absent staining of MLH1 here in the MLH1 patients, and also PMS2 because they formed this dimer. Our MSH6 patient had actually persistent MSH6 staining, but that's something that's well known. MSH6 mutation are actually notorious for not being picked up by IHC. It looked like most of our tumors were actually microsatellite stable, so this was not really worthwhile. However, if you actually take a close look, there might be a small switch here in the length of this microsatellite, but it's certainly not as dramatic as you see that in, for example, colon cancer. So the conclusions were that about 3% of our ACC patients had Lynch syndrome, which is comparable to the other core cancers. MLH1, MSH6 mutations were new, and the prevalence may actually be an underestimate, as we did not employ regular IHC MSI screening, but only based this on the family history of the patients. Another syndrome that can be observed in ACC patients is probably the syndrome we're most familiar with at endocrinologists, is multiple endocrine neoplasia type 1. This patient was initially not followed at our institution, but you see that there had been a pre-existing small adrenal lesion, which then over the course of 2 years grew to this large mass and then grew further. This patient actually then presented with hirsutism and Cushing's syndrome. And the other interesting thing is it's always worthwhile to look out for this. You see these red spots here, which are actually angiofibromas, which are a typical skin lesion with MEN1. Tabarin's group looked in a little bit more detail in the French registry of MEN1 patients. 20% actually had adrenal lesions, and roughly 1.3% of all patients with MEN1 developed ACCs, which at least is a number to, which should warrant to keep an eye on adrenal lesions in ACC patients. So a couple of years again, there was a new kid on the block. There were 2 publications about ACCs with Carney complex. You know, ACC is rare, Carney complex is rare. I think that makes it a likely association. However, I think further observations of Carney complex families and further analysis of ACC patients is needed to make this final. So where are we right now? An update in late 2014. Certainly the 3 big syndromes we encounter are Li Fraumeni syndrome with positive P53 testing, Lynch syndrome, roughly 2%, MEN1, 1%. Again, Lynch syndrome might be an underestimation. And we also encountered a couple of other rare syndromes, which I think in the future we need to see how much that turns out to be a real association. Probably for FAP it is. So what about the unbiased sequencing approach? This is the right side of this, slide here, where you start off with an ACC population and do unbiased sequencing, exome sequencing, and see what you'll get out of that. And recently there had been the TCGA, the Cancer Genome Atlas, with a total of 91 cases with detailed analysis. And this was very confirmatory to what we had found clinically already. There are several Lynch syndrome mutations, P53 mutations, and interestingly also a TNF2 mutation which causes dyskeratosis congenita. However, this is something that's always difficult when you start with a collective that would just collect because the patients had adrenal cancer, because usually there is an insufficient phenotype description to see whether there were other features of this disease. Another thing which I don't want to go into too much detail here is the difficulty of annotation of the variants observed. And Guillaume mentioned that yesterday already a little bit. You know, what's a polymorphism which is encountered in a certain percentage of the population as opposed to a private mutation? We're still in the process of learning about this. What's benign, what's the uncertain significance, what's pathogenic, and the ACMG just recently came out with new guidelines to determine what are pathogenic mutations. The other question is, what's the real penetrance of these mutations? You know, even if you think about P53, it was like roughly 5% of all Li Fraumeni tumors are ACCs, so certainly with regards to ACC, even P53 has a very low penetrance. The question is, of course, what do you do with new disease-causing genes? And in the terms of new generation sequencing, there's always changing algorithms for variant calling. And when we actually took an unbiased approach with the ACC data, we recently found a folliculin mutation, which again is a question. There's conflicting data in literature whether this is pathogenic or a variant. There were several SDHD mutations. These likely present polymorphisms. However, they are also sometimes annotated as disease-causing. Then there are those moderate to low risk alleles like CHEK2, which can be very difficult to interpret. We know it increases the risk for breast cancer, thyroid cancer, but to really establish an association with ACC will be probably difficult. And then there are those new disease-causing genes or possible disease-causing genes, such as, for example, POLG, which is in a recessive manner actually causes the mitochondriopathy, but also has been recently described as a risk allele for breast cancer. So certainly to interpret all these variants, we still need more data on normal and mutation registries to actually classify them finally. So overall, I talked about the approach on the clinical side here on the left, as well as on the research perspective on the right. To summarize, at least according to this data, 5 to 10% of ACCs have an underlying familial cancer syndrome, which is actually 1 in 10 to 1 in 20 patients, which really I think is a number that makes it worthwhile looking for these syndromes, particularly if you see a lot of ACC patients. So again, the message here is familial cancer syndromes are not rare in this population. And it is always a question, of course, how to interpret new genetic mutations, and also whether ACC is truly part of these other rare syndromes where it has been described. So it's always good to keep clinically the lists in mind I presented in the beginning, which are features of hereditary cancer syndromes that can be observed with ACC. I think to conclude, there is a definitive association with Li Fraumeni syndrome, Lynch syndrome, and MEN1. There's a likely association with FAP, which is of course also further substantiated by the molecular finding of beta-catenin activations in sporadic tumors. I didn't talk about Beckwith-Wiedemann syndrome, but that seems to predispose to ACC as well. I think these need a little bit more evidence, but are also possibly associated. I think it's interesting when you think about neurofibromatosis 1. So we actually had one patient with neurofibromatosis 1, and this was a lesson that there is actually always a differential diagnosis in genetics as well, or actually people can have two diseases. She turned out to have actually a p53 mutation as well. And if you actually look in the literature, most of the patients with neurofibromatosis type 1 and ACC are actually fairly young patients. And neurofibromatosis can be actually mimicked by constitutive DNA mismatch repair syndrome, which is basically biallelic Lynch syndrome. So I have the suspicion that that was probably the case for those young NF1 patients. All right, so the recommendations, I feel that all ACC patients should be evaluated with a personal family history with regards to cancer predisposition syndromes. Ideally, that should happen with a professional genetic counselor for a genetic risk assessment, consent, as well as legal information and insurance information about this. Consider mainly the big three in ACC. So all patients should be offered p53 germline testing. And I think ACCs should, just like as it is nowadays usually the case for colon cancer, be evaluated with IHC as well as for possibly microsatellite instability. So what do we do currently for our patients who carry a genetic diagnosis in order to actually prevent ACCs? So for Li Fraumeni syndrome, it's still guidelines are in flux, and most of the screening guidelines actually, or most of the screening suggestions are actually very intensive, and it's hard for the patients to keep up with this. I think it's important to actually raise awareness in the patient for these diseases and in the patient families, in the case of parents of children with Li Fraumeni syndrome. And of course, consider whole body MRI, ultrasound, biochemistry. But even for little kids, actually, MRI usually has to be done under general anesthesia, which poses another risk. For Lynch syndrome and, for example, FAP, I think adrenal lesions should be evaluated if they become evident, but no baseline imaging is currently recommended for this. In MEN1, usually the adrenal glands are well imaged with annual pancreas imaging, and every growth in a patient with MEN1 should be further followed up just with the usual abdominal imaging. So I would like actually to conclude this with a comment on our patients with end-stage cancer. So a lot of our patients are actually stage 4 adrenal cancer with certainly a very grim prognosis. And there's always the physician argument, particularly by physicians who are not familiar with genetics, why test if it doesn't matter for the patient's treatment? I think it really matters because you can actually make it different for the patient's family. And another argument is there's such a low chance to find a mutation, which is true, but that's in part inherent to any kind of screening procedure, and positive findings are almost always low with any screening procedures. And I always think about the gastroenterologist who would not close his practice just because that day they didn't discover colon cancer, right? So I think this is something important to keep in mind. And probably the most rewarding thing of this, when we started this, we were a little bit concerned about how do patients actually react to this additional information, but they, particularly patients with advanced disease, really appreciate the genetic evaluation, appreciate to get a reason for the disease, and they feel they provide something good to their families. So last, I would like to thank everybody, all the collaboration in our study team. I would like to point out two people, which are Victoria Raymond, the genetic counselor who did most of the genetic counseling work and analysis, and Antonio Lerario, who is the main person in the background for bioinformatics analysis. I would like to thank you for your attention, and I also would like to mention that there is an adrenal cancer symposium in Ann Arbor later this year in the fall, so if you're interested in that, visit us in Ann Arbor, and thank you for your attention.